Carolyn, and everybody else.
Well, do you want to share the slides today, or did you want me to do that?
I can share.
Okay.
Let me just get myself together now. Pretty wild that it's been 2 weeks already.
I know. I was like, oh, we have this tomorrow.
And so much has changed. Can you enable screen sharing for me?
Try now.
Love it. Looks like NDD is out for the day, right?
That is correct, but don't worry. We got our system down. So
Love it.
should be good.
I know you've spoken to Marcia.
She's in a meeting until 1. So
Okay.
well,
All right. I'm
sure
gonna
she'll be.
drink some water and go off screen until we
Okay.
get started.
Great.
Hello, everybody. Welcome to today's COVID-19 and MPV city worker briefing. We'll get started after 1. Just wanted to let folks in the room, welcome folks, wish everyone a happy Friday. Feel free, if you'd like, you can share what agency you represent, or share just how you're feeling today, or if you have any cool weekend plans, we'd love to hear it in the chat. For those just joining us, we're just letting folks log in and having folks share where they're, what agency they're with, and if they have any fun weekend plans as we wait for other folks to join. Happy Friday.
I am Mona Lisa. I'm with OLR.
We'll be getting started in just a few minutes. Folks who just joined us again, we're just sharing what agency we're with in the chat. And if folks have any fun weekend plans, we'd love to hear those too. All right, it's 1 o'clock. We know some folks are going to still join. Our last briefing, we had a pretty good attendance. We're still trying to work out some of the kinks. There are some limits to the capacity for the Zoom meeting. We'll see if we max out capacity like we did a couple weeks ago. Hopefully we can expand it. And just welcome everyone to the space. My name is Julian Watkins. I'm an internal medicine doc and public health professional at the New York City Department of Health and Mental Hygiene. I work in the Center for Health Equity and Community Wellness. I've been working for the COVID emergency response and now working on the MPV or monkeypox emergency response. Work with a team of DOH, MH workers and staff to bring these briefings to city workers. When we think about community engagement, we think about the community of city workers who not only represent the community and who not only work for the community, but represent the community and live in communities. And we think that city workers deserve this information as well. And just really want to share and highlight a lot of the hard work from a lot of folks, fellow city workers, to make these presentations possible, to get the most up-to-date information to folks. So we'll get started in just a few minutes. For folks who are just joining, in the chat, we're just sharing where folks are coming from. It's always lovely to see so much broad representation from across the city. And we hope that, folks find something helpful from these spaces to share with, friends, neighbors, coworkers, to really just have the conversation, to raise an awareness. One note, these city worker briefings, they're run and led by folks who come from a public health and medical background. We unfortunately cannot speak to a lot of the major policy concerns and issues or some of the laws and some of the bigger kind of federal things going on. We want to speak to those and at least kind of provide what we can in terms of most up-to-date, feel a bit more personalized guidance for how folks can keep themselves and their community safe. And we'll get started in just a few minutes, just waiting for our friend and colleague, Dr. Wong, to join us from another meeting that may be running a bit over. Welcome. Well, we have a lot to unpack today, so I'll just get started. Again, welcome to everyone who's joining the meeting. Hopefully, we'll see if folks will continue to as folks continue to join. This is our second of our COVID-19 combined COVID-19 and MPV or monkeypox city worker briefings. We had our first one last 2 weeks ago. This is a continuation of some ongoing work that we were trying to do to create space for city workers to get information. This is run by a health department staff for other city workers to bring the most up-to-date information in terms of the public health guidance, some background for the medical information, and some recommendations.
I cannot hear anything.
We can't speak to the policy. As are other folks having sound issues?
We can hear.
We can hear you.
Okay.
Hear you.
Thanks. Yeah, so again, can't really speak to policy stuff, but we definitely hope to in a future space like this to bring some HR folks so that folks can answer some HR questions. But we'll hop right into it. So we're going to start the presentation with covering some updates in COVID-19, sharing where we are right now because this is an ongoing crisis. Contrary to popular belief, COVID is not over. And as we wind down summer and enter the fall and winter, cold and flu season, we really do want to raise awareness for folks and have folks really thinking, reconsidering what is our fall and winter COVID-19 safety plan. And then we'll hop right into to MPV because there have been a few major updates that we want to leave some time to unpack. For folks who cannot hear, maybe try figure out what's going on in your tech world, because I think a lot of folks have gotten everything together in terms of folks are having or can hear. So let's hop to it. So just wanted to share a summary of kind of where we are overall as a city of New York in terms of COVID by looking at the COVID-19 data. As a public health agency, we really try to follow the data to help us to help guide our response. All of the data again is that we share in today's presentation is available at the New York City Department of Health and Mental Hygiene website. You can go to the COVID-19 page and go to the COVID data page. So this is a summary of the last 7 days of what's been going on in the city in terms of COVID. Luckily, well, I'm happy to report that we're definitely seeing the COVID numbers moving in a direction in the right direction. We're seeing that overall the percent positivity is going downward. The percent positivity is a measure of cases which are going down, and the case rate per 100,000 folks. Those are going down as well. We're also seeing decreases in hospitalization over time. We're also seeing a decrease in deaths across the city due to COVID-19. All really, really great that's where we're headed. And for the next slide, we'll just kind of look at trends. So we track data by neighbor of the 5 boroughs, but I like to show this line to show that these trends are across the five boroughs, where we're seeing cases are starting, the numbers are moving in that right direction. It's important that we're all aware and very vigilant that we know that what goes down can sometimes go up. So just really as things start to get cooler and we kind of get into that season, again, we always talk about having this conversation. Now, in terms of eligibility, the eligibility has not changed recently. I think that when we talk about eligibility for vaccines, 6 months is the youngest that folks will probably be getting vaccinated against COVID-19. So folks 6 months and older are eligible. Folks are getting vaccinated across New York City. We'll share some of the data in terms of the percentages and numbers. In terms of the vaccine world, there has been a lot of headlines. The Novovax vaccine was approved for use in children. So there's another option for children that uses a different platform for immunity. And then folks are also hearing that the federal government is really trying to make a new and updated COVID-19 booster available, maybe as soon as the next few months. That's really encouraging, understanding, the vaccines that we have, they were developed in 2020 in response to, can someone mute? I hear a little crinkles. They were created in 2020 in response to the wild type or to the original strain of COVID-19. As folks are pretty familiar, we've been through a few different strains, and right now the dominant strains are the Omicron strain or Omicron subvariants, known as BA.5 and BA.4. So these new vaccines are going to be tailored to cover these BA.4 and 5, I believe, and also the original strain. So hopefully, we'll see an expansion of the vaccine's protection against severe disease, against severe illness, and hopefully help quell some of these post-vaccine infections. That said, and part of the overall COVID response, the boosters are a key feature, as most folks have a good portion of folks completed their primary series in the earlier parts of 2021. So we're a year out. We know some of that folks have been boosted, but we do have some space for improvement. So again, just really wanted to highlight that boosters are an important part of this conversation, and we hope to keep that going and report some positive results when we learn more about the upcoming updated boosters for the winter. And again, the vaccines are free. They're still strongly recommended. They're safe and effective. It's been a while since the vaccines have been out there, and again, we haven't so far we aren't seeing months and months later folks having side effects or unknown side effects. So just keeping an eye on that is important. And we'll go to the next slide. So this is some of the data around who's getting vaccinated in New York City. So to the left, you can see the adult data. We won't go too in detail, but I think it's a nice visualization to see where we are, where at least 6.5 million folks have gotten at least one dose. And we know that on average, most folks are completing their vaccine series once they've started. That's really that's really impressive to know that that many folks have been vaccinated. You can see where we are in boosters in terms of folks who are eligible for boosters or gotten additional doses. Around a little over 47% have gotten additional doses. I'd like to see that higher. Hopefully, for the 2022 fall winter, we can get our boosters up. The number of folks getting boosters up. Looking at adults by age range, one of the demographics that have some of the lowest vaccination rates are folks who are 85 and older. I think some of the data could be cleared up a bit because some of that is based on some census data from even before the pandemic, and we do know that the impact of this outbreak has affected the folks at the our most senior folks. So that may not be an accurate representation of folks who are still with us and their vaccination status. To the right of the screen, want to highlight that we have added some additional data points to the webpage, which has shifted a little bit of the vaccination coverage. In some of the finer print to the very bottom, you can see that we are now reporting the data for children 6 months to 4 years old. So that kind of so now it's all children are included in these numbers, and we can see for the older children, 13 to 17. Vaccination rates are really good. Around 92% have gotten the first dose, and 82% fully vaccinated. From folks in that 5 to 12-year-old range, we still have a ways to go. Around 49%, or about half of children within the 5 to 12-year-old range, have gotten fully vaccinated or gotten that primary series. And when we look at the children 0 to 4, these are the children who are the most recent group that became eligible. We actually see the baby vaxes, not that many babies have gotten vaxxed, but we really do like to highlight and raise awareness of that group, because some of the other data that we saw, we know that kids, thankfully, children are not getting. On average, most children are not having, really bad infections, really severe infections. But what we are seeing across New York City is that since the rise of the pandemic, we've seen children have been hospitalized, and children in that 0 to 4-year-old range actually have been hospitalized at higher rates than some of the other children. So just really what we can, thinking about how we can protect the youngest amongst us from severe illness, from hospitalization, which I think is just, not good for anyone to see a young child in the hospital, and also just the financial and other burdens that hospitalization can cause to a family, thinking about how vaccines for our youngest New Yorkers could help. Getting tested, testing is still a key factor in breaking chains of transmission for COVID-19. As we get to cold and flu season, I think it'll be really important for folks to have some home tests available. If folks do wake up with that sore throat, with congestion or other things, to really consider COVID-19 as part of just, if something feels off, just rule it out, just to make sure that you don't have it, and that make sure that if you do, that you don't spread it to someone. So getting tested, especially in times of high transmission. So thinking about the fall winter, that's something to think about. And we're recommending folks to get to test if they have symptoms. Folks, these are recommendations. No one's forcing it, but these are just some ways to look at testing, kind of keep in our toolkit for getting tested after contact with someone who knows if they had it or not, if we're going to big gatherings, and also thinking about visiting. This isn't a part of the main guidance, but what we kind of like to think about is, if we're going to see someone who may be higher risk, if we live with someone or go visit a family member who may be higher risk, to really, get tested a few days before going to see that family member, and actually kind of practicing some risk reduction behavior in those days leading up, so you don't bring unwanted gifts to visiting when you visit family members. Again, we always like to really talk about the treatment options that are available. Again, these are not a substitute, but just letting folks know that these treatment options are available. They're really, really helpful and impactful in reducing folks from progressing to really bad symptoms and being hospitalized or worse. There's the antiviral pills. There's also the monoclonal antibodies, and just raising awareness that folks are still getting testing positive. Let's just having that awareness that if you test positive, there are treatments out there that can actually help prevent progression to worse disease. Not a substitute, but something nice to have in our toolkit in case someone that we know or love does test positive, to let them know, hey, if you are if you are at high risk for a severe infection because of age or an underlying condition and you have symptoms, there's some things that you can do to make sure that this doesn't get any worse. Before we go into monkeypox, don't have much around long COVID, but I think that's something that we should always be thinking about and have on mind. We know that that a lot of folks are affected and dealing with long COVID symptoms. And at a future briefing, would like to kind of take a moment to talk about long COVID and where we are, recognizing there's a lot of folks who are suffering from this, and really just trying to make sense of it all as we in public health and healthcare try to make sense. Okay, so now we will transition into MPV. It's a similar presentation from last week, just to kind of bring folks up to date. We'll expand the conversation around some of the updates around intradermal dosing, explain what that is, and share what we do know so far about intradermal dosing, and kind of just give some updates of where we are as a city. So New York City remains the epicenter within the epicenter. So in the United States is the country with the highest number of MPV cases. We remain that way. If you look at the map to the left, this is from the CDC. The CDC has a lot of really great resources. Recommend folks checking the CDC if they want to dig deeper. You can kind of see the deeper blues represent states or territories with higher case counts. And the United States, we have nearly 17,000 cases of MPV as of yesterday. In New York City, as the epicenter within this country, we have over 2,000, nearly 3,000 cases of MPV in New York City. Luckily, or thankfully, we are seeing some signals that some of the rates of transmission are going down across the city, but that's just reassurance that vaccines have been are offering that protection. B, acknowledging that communities have taken action to raise awareness, to modify certain behaviors, and also to get the message out and support folks and get folks vaccinated, and have these difficult conversations. So just really want to highlight that we are moving in the right direction, but we have a ways to go. We'll talk about some of the distribution of resources later. So we've talked about symptoms a bit, but I think just really highlighting that the symptoms can typically develop 2 to 3 weeks after an exposure. And the most common symptoms, again, are this typical rash, which tends to be quite inflamed, very red. They can be itchy and painful. They have these pox-like lesions. They can look pimple-ish, but one of the main features that they do have is like this indentation or like a little dimple in them. Also, they can tend to the lesions. They can be in some typical places. Folks typically tend to get them on their hands and their face, and on the body, on the torso. But in this more recent outbreak, we are seeing it in some other places, in these mucosal surfaces, the pink parts of our bodies. We're seeing that as well. The disease course can last from up to 2 to 4 weeks without treatment, and also a part of it is what we call like a flu-like or COVID-like illness. Usually in the earlier part of the disease course, often before rash or sores develop, but sometimes at the same time. And folks are having fever, chills, swollen lymph nodes, headache, muscle ache. So folks, it was described as mild early, but I think just tempering that with, depending on where the lesions can be, folks are experiencing a lot of pain and tenderness and discomfort. All right. So how does Mpv spread? So there's a lot of talk, and people are calling it an STI, and what is all of this and all of that? At the end of the day, this is a communicable illness, right? This is a disease, a virus that is passed from person to person with close contact. Luckily, this contact is generally not through casual or passive contact. It's more through a more prolonged contact. So we're seeing folks, who share the same bed, folks who are sharing clothes or sharing, who are living together. These are folks who are like in enclosed spaces, with close contact over an extended period of time. Spending the night and at a social event and everything in close quarters. That's how we're seeing this being transmitted. not through like casual touch or not through the air. We know that there can be droplets, there can be virus found in some respiratory droplets, but we think that it's pretty inefficient in transmitting respiratorily, especially in passing. The larger concern is for the large droplets for in close places, in very close proximity with someone who's infected and unmasked. So in this current outbreak, acknowledging that some of the direct contact is occurring during sex or other intimate contact, I think is important, especially for in some of the social circles where this is spreading right now. Still, the jury is still out on spread, but we think that spread is limited to when folks are symptomatic. We don't think that there's a lot of folks who are quote unquote asymptomatic spreading this, not like silently spreading, which is a good thing. So that it can be recognized and diagnosed when folks do develop symptoms. When the infectivity or folks are a lot or less contagious after the sores have healed. So after the sores go through their life cycle and they've actually healed up, scabs have fallen off, and you have a fresh layer of skin underneath, that's when folks are no longer contagious. So who is at risk? Anyone with skin walking around is potentially at risk for infection with MPV. Anyone, regardless of sexual orientation or gender identity, can get it. We are seeing this spreading across the city. I think as we're starting to get containment, we're seeing other jurisdictions where we're seeing spread. We will definitely see more cases. We're not through this yet as a city, or as a country, or as a global community. And I think there's a lot of reasons. Some of the rashes and sores can be confused with other infections or other skin findings, especially early in the course. One singular lesion, within your hairline or in a place where you can get acne can be confused. And so we know that. We also know that the testing capacity and access to medical care is limited. And folks have various barriers that prevent them from seeking care, including the fact that stigma is so big, and folks, some folks will have to make important survival decisions to kind of protect themselves, and may not seek care, especially when we see the way that things are being talked about as purely sexual. It's important to acknowledge that the folks who are at the highest risk are folks who are in the social and sexual networks of gay, bisexual, or other men, cis or trans, who have sex with other men. Also, it's a big community. So trans folks of trans experience, folks who are gender nonconforming or non-binary, who are in these social circles, also are at risk. So definitely extending vaccination to those groups. Some of this is a thing. It's a numbers game. So the more contact with folks who you may not know well, or who may be anonymous, can put folks at risk. So these are some things to be thinking about our own personal risk for COVID. For MPV. I think another point on this is, if for folks don't see themselves reflected in some of the highest risk groups, I think it's important to kind of look at it as not as, oh, this is their problem or I'm good, but think about it, these are our friends, these are our neighbors, these are our coworkers, and we want to make sure that we can support them, destigmatize things for them, and make sure that folks are okay if they may be at higher risk, because we all live through COVID-19, and it's another thing to kind of now see that there's another kind of pandemic or epidemic happening. So just really make sure that we can hold our our siblings down, our friends, neighbors down, our community down, especially for those who may be at higher risk. So there's many different things that we can do to protect ourselves and others, but one of the best things to do, I would say, is knowledge, reading about this, learning more about it, so that we can actually counteract some of the stigma, counteract some of the misinformation that may be out there, and really make sure that the message is out there, so that we're helping to support folks versus demonize or otherize folks or blame folks. We don't want to blame folks. We just want to help folks get out of this, so that we can all get out of this. So and some other things that folks can do, for folks, while this outbreak is out there, Dr. Wong and I, we come from the HIV, STI world. So risk reduction, harm reduction, whatever we can do to lower our risk, maybe decreasing the number of partners, or just having that conversation with a partner, if they may be a new partner, like, how have things gone? Have you been vaccinated? Are you feeling okay? What's going on? We encourage folks to have those conversations, and then to avoid certain spaces where we know that that transmission may be a bit higher. So places where folks may have closer, more intimate contact in larger gathering spaces, such as certain types of party spaces and other social gathering spaces. There's a lot of information for keeping folks safe at home on our website, also on the CDC website. There's also guidance about care at home in terms of washing clothes, how you can keep folks in your house safe if someone does test positive. Just wanted to highlight that. So this is the big news around the vaccines. So there's this new mechanism. There's an alternative way to administer the vaccine, which the FDA has authorized pretty recently, and that New York City is following suit. So basically the traditional way that this vaccine is administered is called subcutaneous. Below cutaneous, the skin, so below the skin, in the tissue beneath the skin, fatty tissue, what have you. But there's other different ways that we can administer this vaccine, similar to other medications. You can take liquid medications, you can take pills, you can take creams. So with vaccines, there's different ways to administer, and so there's an alternative way to administer called intradermal. So intra meaning between, dermal meaning skin. So we have multiple layers of skin our skin is layered, and our skin is a marvelous one of our largest organ. It's a key part of our immune system. It's a physical barrier preventing transmission of a lot of bacteria and other pathogens that are always trying to get us. But the skin also is amazing because it has its own specialized immune cells. And so this intradermal administration is something that has been used for other vaccines, and it was tested in an earlier version of the Jynneos vaccine, this vaccine that we have. And it was shown that folks, if they get they tested different dosing in intradermal administered. So usually in the space on the forearm, we can't see that, but on the forearm, a very shallow, small needle to inject a small amount of the vaccine, 0.1 milliliters of the vaccine under the skin was shown to produce and what we call immunobridging studies, or studies checking antibody response, was shown to elicit or produce similar immune response to the subcutaneous route. The FDA and the CDC have chosen kind of move forward with that route because basically for one dose in that route requires 0.1 milliliters, or 1/5 of the dose required to get the similar immune response in the subcutaneous route. This is all to respond to the fact that the supply does not meet the demand nationally, especially in New York City. Does not meet the demand as a mecca in the queer community, but also the largest city in the country. And so this is in response to that. Hopefully we can see more vaccine become available. There are more vaccine appointments that are happening. The rollout of the intradermal vaccine program has already gotten started. This will be a gradual rollout, understanding that takes a different the technical skills of injecting the intradermal needle. A lot of folks aren't doing intradermal injections in their everyday. Folks may be familiar or have already had an intradermal injection. For folks who have gotten TB tested, it's a similar thing where you get the little bump on the forearm. But for this one, for MPV vaccine, you don't have to go to a medical provider in 3 days and get any reading or anything. The New York City Department of Health, I mean, we have some information, but we also are acknowledging that a lot of the data isn't there. We don't have a lot of studies in real time, in real people against these viruses. I think that's because we did a really good job eliminating smallpox. So we will see a lot more data on prevention, on efficacy of these vaccines in real time. But I think looking at where we are in New York City, at some of the numbers and even in other parts of the world where the vaccine programs have happened, that we know that they are having a major effect. So just wanted to highlight that there's a lot of information that's available. I think the CDC has some of the best information on intradermal. They have frequently asked questions, which we can share in the chat for folks if they want to know more, especially just around what are some of the side effects. Intradermal injection, folks have some increased local tenderness and can have some discoloration at the site where they get the vaccination in that forearm. There's a few other possible long-term complications that we are aware of and that we want to investigate a little bit more specifically about. Some folks can have hyperpigmentation or increased pigmentation locally, like in the spot, that can last for a few months. So just really understanding what that can mean. And we also know that some folks have developed keloid scars. So these are just like thicker scars that can occur at sites of trauma in the skin. So that's another thing that we're keeping an eye on as well. That said, as we are transitioning to intradermal, for folks will see that there's subcutaneous and intradermal across the city, depending on the site. And the great thing is this is the same vaccine. And so if someone who cannot tolerate or for whatever reason cannot accept or cannot take the intradermal vaccine, folks can still receive the subcutaneous administration. All right, this is a current eligibility. Hopefully we'll see this expanding pretty soon with the expansion of vaccines. Right now, the vaccines are limited to the groups which represent the majority of the cases. So folks who identify as gay, bisexual, or other men, cis or trans, who have sex with men, other folks of trans experience, other gender nonconforming and non-binary folks are included. Folks age 18 and older right now, but the FDA authorized subcutaneous injection for people younger than 18. So we will hopefully see an expansion around there. And then for folks who may have the highest risk, as for folks who may have multiple or anonymous partners. Some other folks that should be really thinking about getting vaccinated, if they have partners who are known to have symptoms or something that may be concerning for MPV, those folks should be considering getting vaccinated. Also for folks, if folks meet partners through online applications and social media platforms, we've found through some of the case investigations, we found a lot of folks have met partners and possibly got exposed through meeting folks on some of the apps. So Grindr, Tinder, Scruff, Sniffies, all the other apps. And also for folks, going to certain social gatherings where there's a lot of, a lot of folks in proximity and in dark rooms that can possibly lead to transmission. And then finally, for folks with medical conditions, folks living with who have uncontrolled HIV, or folks who have other conditions that may affect their immune system, and then for folks who have some underlying chronic skin disorders rather, who should be thinking about getting vaccinated. For folks who have symptoms, calling 311, talking to a healthcare provider is important. Avoiding physical contact until folks can get a diagnosis. Isolating at home and separating from folks. Wearing a mask if you have to leave the house for essential needs, and making sure to cover lesions. We know that these lesions are the most contagious. There was a study in Spain. May have mentioned this a couple weeks ago. A study in Spain just looking at how much virus is on different parts of the skin. Open sores definitely contain. They were found to contain over 1,000 times the amount of virus that was on someone's plain skin that was not a sore. And so these sores are where the virus is at. So just making sure that folks cover up those sores is really important as well. Care and treatment, we've kind of been to that before. Our website, we share a lot of some of the things that folks can do for home remedies, over-the-counter remedies, and we also make sure to highlight the fact that there is a treatment out there originally designed to treat a cousin of monkeypox, smallpox, but there is thankfully, it's active against monkeypox as well. It's called TPOX, pretty well tolerated. It was authorized through CDC through a special authorization for use. And folks the barriers to getting this medication have definitely been brought down, and a lot of folks are getting it and tolerating it well. Won't go through all of these other things that folks can do for supportive care, but our website outlines this in a bit more, which I think is really important. So what can we do to keep, what can we do as just concerned citizens, as folks working at the health department or folks working at city agencies? So what we can do is direct folks to good information. Knowledge is power, getting folks in the know, demystifying it, destigmatizing this thing, and just getting the facts. What is it? What can we do? What is my risk? These are all things that we can do. Getting folks connected to the right information is trusted information sources. For folks who want updates, there is folks can get the text alerts. You can text Monkeypox or Monkeypox ESP for updates in Espanol to 692-692. We have palm cards and other materials for use. You can post things online. You can see an example to the right about some of the things that folks can do to protect themselves. Destigmatizing, can't say it enough. Really getting the message out there. And we can hold the conversation that certain communities are currently being disproportionately or over affected by this, but this is in no means quote unquote a gay disease or a trans disease. This is a people disease. This is affecting our neighbors and our friends, and really making sure that we can spread information and not spread disinformation, and know that the community unfortunately is under attack. There's a lot of political and other attacks against the community, and this can only just open up things and further stigmatize folks. So really doing whatever we can do to actively resist some of these things that would that could harm communities. Learning about symptoms, and then directing folks who need support. If folks need mental health support, that's there's a lot of resources out there. Can't say it enough, can't stress enough. And then also I can't remember the name of a group that was actually providing meals for folks who are diagnosed with MPV. So there's a lot of really good work going on out there, and just connecting folks to resources and information, and making sure that we're in this together, and that whatever we can do to help support folks and get us through this. This is hopefully a temporary crisis. We can get to the other side of this, but we can do it together. I did want to highlight I'm done with this portion of the presentation. Made pretty good time. But on our website, if folks want to see some of the demographic data, we actually have it broken down: cases, case demographics, which groups, what parts of the city the numbers are, also by race and ethnicity. But we also are tracking and reporting the data around vaccination, which groups have gotten vaccinated, where folks live, what are the ages. All of that's being tracked and being reported out on the website, and we can go through that on our next meeting, or we can talk about it now a little bit. I will pause here. I will stop sharing my screen, and we can hop into the questions. 1 second.
Great. Hi. So I'm Marsha Wong. I also work for Department of Health, and I usually help with the Q&A section. You can all hear me okay? Yvonne's okay? Okay. While Dr. Watkins takes a break. I think I'm going to go ahead and start with the COVID questions first. I think there's just a few of them. And then we can sort of jump to the monkeypox questions. I'm not sure if we'll be able to get to the questions in the chat at this time, but we will try our best. But I did want to get to the pre-submitted questions first. And so there are some questions about the removal of the 5-day isolation period. Sorry, voice is low. Can you hear me okay? This is probably.
I can hear you fine.
Okay.
Yes.
All right, great. Okay, great. Thank you. So I think this question is actually regarding the removal of quarantine. So actually, CDC did say that, and we're still sort of awaiting sort of formal guidance from New York State, but there is a removal of, if you have been exposed but do not have COVID, so someone close contact got COVID and you were exposed to that person, then you do not need to quarantine. There is still stipulation that you still need to wear a mask for 10 days, and also this may not apply to certain settings, but for the general community, quarantine is no longer required. But this does not apply to people who actually have COVID. If you do have COVID, you are still required to stay home for 5 days. So just to make the differentiate between isolation, you do have COVID versus quarantine, you've been exposed to COVID. The other thing, there's been some questions about rebound. Yeah, there is this rebound phenomenon. I know it's sort of been linked to treatment with Paxlovid. However, we already knew that this sort of was happening, maybe in around maybe 10% of cases, and it happens regardless of treatment. And so whether you've been treated or not, certainly if you qualify to get treatment for COVID, definitely get on treatment. It does really work. It works well. It really prevents hospitalization and death, and people feel a lot better. It's not the same issue as this rebound COVID. Even people who did not get COVID also have rebound, meaning their symptoms went away and then came back. I don't think we really know why that happens. We don't think it's related to whether or not you receive treatment for COVID or not, but just that we do know that it can happen in sort of, in a certain percent of cases. It's not a high percent, but it does sometimes happen. Okay, so booster shots. Yeah, I guess for booster shots, I think it's a very personal decision. And all I will say is, we are awaiting sort of the Omicron specific boosters potentially in the fall. I don't know any more than that, aside from what Dr. Watkins already mentioned. And whether or not you decide you want to get a booster now or not, I think that's a personal decision for you to make, sort of, if you do qualify for a booster. Again, not everybody qualifies for that second booster. So I think that's sort of something you can discuss with one of your primary care physicians, or if you don't have a primary care physician, you can also call 311 and sort of talk about it with a clinician about your specific scenario. Okay, so I'm going to move on to monkeypox because I know there's a lot of questions. I guess I know we always talk about this, but we really want to emphasize that this is largely still, most of this has been spread through intimate contact, intimate and sexual contact. So I just want to make sure we know, even though you are hearing lots of different things in the media, you may hear of a few pediatric cases, a few cases that are outside the LGBT community, but just want to center that right now the community that's being affected the most is the LGBT community. So that is where resources are going. There's extremely little spread. I'm not saying there's zero, but extremely little spread outside of sort of sexual and intimate contact. So with that said, that's why we are focusing our resources and vaccines where they are being focused, and we really need to center the needs of this particular community. So I just wanted to make that very clear that we really want to really help the communities that are being affected and suffering the most, and that this is really not a very good virus. I think there's a question about why aren't we in lockdown? This is a different virus than COVID. It's not spreadable the way that COVID is. It's not really, it really isn't airborne, quite honestly. That's just not what we're seeing in the data. And so, do we think it'll spread through schools? We don't really think so. And is there possible, so I just think in general, like, this is why, I know there's a lot of anxiety about this. I know there's a lot of concern, but at the same time, just what we're seeing in the data is just not that. So I know people are carrying a lot of COVID trauma into this. This is not COVID. We don't need to be locking down. And we don't need to be harming the community more than it already is. So I think we have to be very careful in terms of our messaging, as well as sort of how we approach this. So I think that's sort of, there was some questions about, the WHO stating that monkeypox is transmitted by gay and bisexual partners. Why is this a national concern for everyone? I think given the numbers of cases we're seeing, it is a national concern. This is a public health emergency. And it doesn't mean that it won't spill over into other communities. But I also need to say that I don't know how to tell you that you should care about people who are different than you. And I think that's what I would say, regardless of whatever public health emergency is going on, regardless of what sector of New York City it happens in, these are still things that we need to care about. And so that is why we are caring about this, even if it's only affecting certain sections of our population. This is just about caring for people and caring for New Yorkers. So I just felt like I had to say that. Announced, I don't know if you want to add more to that, but I just felt like I knew to level set with folks that this is something we should be caring about.
I think also the other thing is just practical. This thing spread in Nigeria in circles that weren't gay, bisexual networks for many years, and no one, the global community didn't really intervene, and we can see what has happened. And how the spread, and so we know that this can spread to anyone with skin walking around. So lucky for the bigger picture, it's in a pretty insular kind of community, but folks, queer folks and folks in our social networks, we have children and we have family members, we have we live lives, full lives with a lot of folks. So it's really about what we can do to really stop this thing. I will reshare the link to disinfection. I saw a question in the chat. So right now, the Centers for Disease Control are not recommending for medical providers to get vaccinated for prevention. Folks wearing standard PPE, personal protective equipment. The risk for getting infected is actually quite low. So that's why that hasn't been extended to all healthcare workers. Taking care of folks with MPV, and the CDC it outlines that a little bit more. What else?
Yeah, questions about the second dose. We're right now really prioritizing first doses. So right now we don't have enough allocation to provide a second
doses
dose.
Are coming soon. So hopefully as soon as next week with this transition into the intradermal, we'll be able to actually open up second dose appointments pretty soon. Folks should actually be getting contacted shortly.
Great, thanks. And then I don't think you need to present proof of first dose. I think you can just tell them, but I think there probably will be more information coming on that. I don't know if you've heard anything else.
Yeah, there should be more coming. And in New York City, with the declaration of the emergency, I think that most folks who are getting vaccinated, or it's being reported to the city immunization record system. So folks, if you get vaccinated in New York, folks should be that should be tracked, similar to the COVID vaccines, where those were tracked and reported.
There's a question about, I'll just read it. Why wasn't there an announcement strongly advising public to stop continuing activities that spread monkeypox in the same manner as COVID? I think I sort of talked a little bit about that. They felt like it was one-sided, in fear of receiving pushback from the LGBT community. Children should not be exposed to this, especially now that school is about to start. I think for the last part of that question, we don't think that this is going to spread widely through schools. So we are keeping track of that. We are there are plans being put in place for the start of school. But this, again, just the way that this is spread and the data that we're seeing, this is just not the way it's going to spread. I'm not saying, again, that there will be zero cases, but at the same time, this is not the predominant mode of transmission. I also think in terms of messaging, I think there were some people that were sort of arguing for sort of an abstinence-based messaging. I think given our experience, which I think is what this question is trying to get at, given our experience, again, decades at this point in sexual health and HIV, we don't really think that's the way to go. I think there's lots of data to support a harm reduction message rather than an abstinence message. I think we've seen this, with the abortion debates among, wouldn't have to have abortions if people could just stop having sex. Like, it's just the same arguments are being used over and over as a way of further harming this community. So so that's why we are taking a harm reduction approach rather than an abstinence-based approach. And I think we do have, experts in messaging. We have community boards that are part of this community, and we're not always great at it, and we're certainly not perfect at it, but we really do. I think the communities that are affected the most need to be centered, and sort of also they are experts in their own communities. So I think the messaging does really need to come from the LGBT community if this is the community that's being the most affected. Okay, so let me go ahead.
As you look through the other questions, I can respond to a few quick ones. So there was a question in the chat if immunocompromised folks who are well controlled don't need to get vaccinated. So again, it's not necessarily about who you are and what your conditions are. It's about possible exposures, So for folks, if they're well controlled, but if you have multiple partners, if you are, if you know folks who have monkeypox, that's when folks would consider getting vaxxed, or should definitely strongly consider getting vaxxed, not necessarily because of who you are. It just kind of depends on where this is circulating right now. In answer to that.
Yeah, I just want to, sorry, I'm going to shift gears just for 1 second in regards to polio, because I think there were some questions about polio, and there was a question last meeting about polio, about who should get that extra vaccine and who is considered high risk. And that also, there was a question in the chat about whether a sanitation worker needs to get vaccinated, I think in relation to monkeypox. So no, if you're a sanitation worker, work with sewage, you don't have to be worried about monkeypox or COVID for that matter, but you do have to be worried about polio. And so the recommendation actually is to get an extra vaccine for polio if you do work with sewage. That is considered a higher risk of exposure for polio. So that is something, hopefully that's a message to our Department of Sanitation. But that is something to consider. I would actually consider a polio vaccine in addition to sort of the childhood polio vaccines. That's the recommendation right now. We are seeing polio in New York City wastewater. I don't think we've had any cases as of yet.
No, the majority of polio cases do go like undiagnosed, or people are not symptomatic, which is a great thing. But again, this moment that we're in right now, even looking at certain demographic groups, or who's being the most affected from COVID-19, folks who aren't vaxxed, children, and other people who are at risk and who are being affected with polio, and all these other things. It really gets down to public health messaging and really getting us back down to the basics, the things that have kept folks safe, these proven interventions that have extended human lifespan over the last 100 years. All of these things are really important. We have to really return back to some of these basics, these fundamentals that have been really attacked by some negative forces to really sow doubt, because we don't have to be here with polio, with this vaccine out there. I mean, and even just thinking about supporting some of these essential services and needs to function in society, places like all of us civil workers working to keep the lights on in the city. We have to make sure that the health department gets funded, all these other essential services get funded, so we don't so we can respond accordingly and with our full might. I'll stop soapboxing.
Okay. I'm just going to kind of scroll back to the top, hit some of the COVID questions again, and then keep going down the list. If I recently had COVID, how concerned should I be if my rapid tests are negative, but my PCR remains positive? Can I still be contagious? So the answer is no. If your rapid tests are negative, one, it's if you do the isolation for the 10 days, you don't have to necessarily do a rapid test. Pretty much after 10 days, you should be good to go. But if you happen to do a rapid test, and if it's negative, it's totally fine to leave isolation. I think there's questions if you were to keep getting positive rapid tests at the end of the isolation period. I think it's probably still likely okay to leave isolation, although the data is a little bit less clear. The PCR sometimes can be positive up to 90 days. And so the recommendation is actually after you test positive to actually not do another PCR. The PCRs do stay positive for quite some time, and sometimes they can take a while to become negative. It does not mean that you are infectious to other people. So pretty much like what I would think of is you get COVID, 10 days later, you should be good to go, I think is the bottom line. Isolation period is 10 days. Questions about how accurate is data. I definitely think we're underestimating the number of COVID cases, so I wouldn't necessarily trust the data page in terms of numbers. But at the same time, what I look at is sort of the shape of the curve. So you can see cases going up, cases going down. but we don't know like what the true estimate, what the true number of cases. A lot of people aren't even testing anymore, or people are using rapid tests in the vast majority of cases. So the cases actually may be something we don't even know, maybe 5 to 10 times more than what we're seeing on the data page right now. The data does only count PCRs. But at the same time, you can tell when transmission is high just based on the shape of what the curve, goes up, comes back down. So that's how I use the data.
Yeah, and I think, I think to kind of link this question around trusting the data with COVID to other things, we don't have an accurate estimate of how many folks get the flu each year, how many folks get, seasonal, seasonal colds, but I think, following trends, we can kind of make as informed decisions as we can based on, what we are seeing in some of these proxies. And I think, those early days in COVID when we were able to kind of get these accounts and know all that, that was a very particular time. That was when we didn't have interventions, we didn't have treatments, and it was a very brand new. And so, as we are kind of transitioning into, living with this thing, that's why we are seeing some things, we aren't seeing things as accurate, but I think these trends are really helpful. And I think also just recognizing, the bigger trend seasonally, COVID is mimicking, mimics other, other respiratory illnesses for cold, for the winter, for fall and winter, but then also just knowing that this thing also has its own, follows its own path depending on circulating variants. So I think it's just that living with COVID, it's a bit more of it's a bit moodier, I would say, than some of these other things, just in terms of like, it doesn't always follow just the seasonal trends in terms of when things spike.
Okay, so I'm going to switch to monkeypox and try to hit up the last few monkeypox questions. We have about 4 more minutes. Questions about monkeypox exposure in public areas like gyms or laundromats. Really don't think that's not what we're seeing in the data. Is it impossible? Again, not zero risk, but at the same time, like extraordinarily low. So I would say in general, like I've been fine moving about public life, gyms, laundromats. I do all that stuff. And I do not, monkeypox is not in my mind when I do those things. So I would think the risk is probably higher, being hit as you cross the street by a car or a bus. Question about pets getting monkeypox. There was a resource in the chat regarding pets. Again, extremely rare, but it is possible. We have had a few case reports published surrounding sort of pets. I think there was a dog that got it from somebody. So again, we recommend being careful. Obviously it's hard to like not interact with your pet if you did have monkeypox, but definitely covering the lesions, I think can do a long way to prevent spread to humans as well as pets. But again, extremely rare occurrence that this is happening. Okay, I think we talked about the second dose of vaccine. Dr. Watkins, do you know, are we increasing access to condoms at social gatherings? I wouldn't be surprised if that's happening. I'm just not super aware.
Yeah. So the great thing is actually a lot of these major social spots actually kind of already participated in the NYC condom program, and folks can get condoms pretty easily in New York City for free. Of course, there could always be more. I'm not sure if that's part of it, but we do have teams of folks who go out every night. I literally have on my calendar nightly, folks are going out into communities, talking to folks, sharing information, signing folks up for vaccines, answering questions. So I'm not sure if folks are walking around bringing the condoms with them, but we definitely are encouraging folks to use condoms just because there's a lot that we don't know in terms of sexual transmission and bodily fluids. But I think the bigger part of the conversation is just, risk reduction and really looking at that as the way to kind of help folks get through this versus, thank you, Brian, another DOH employee. Yeah, the only way we get through this is with the risk reduction and these other things, and also as a community. We have to really look at this as how can community respond to this, and not just offload it all on individuals. We have to kind of come at it as a united community.
Clinical providers who are immunocompromised, should they be preventatively vaccinated from monkeypox? I would say the answer is no. I think Dr. Watkins touched briefly on this. We really haven't seen like healthcare worker transmissions. And again, the vaccine is based on exposure rather than sort of health of the individual.
The
That said,
standard precautions are really great. When folks, providers wearing the standard precautions, the whole suit, everything else, like it's really good at preventing infection. It's just folks, making sure that they stay vigilant. The risk is low. Yeah,
certainly if you do have a direct exposure to somebody, we do look at those case by case. And so someone would reach out to you for a vaccine as a sort of what we call post-exposure prophylaxis, if that was the situation where you did have a really, really close contact. Even if it was clinical work, we do have a healthcare worker team that does that. With that said, I think if somebody were to get monkeypox and was like very immunocompromised, then we would also, you should definitely, consider treatment. So I think that's the other piece I would say, just in regards to sort of just to round out the immunocompromised situation when it comes to monkeypox. Is monkeypox considered an epidemic? I think depends on your definition for epidemic. And I think, but it certainly has been declared like a public health emergency in multiple forums. I would say, yes, it is an epidemic. An epidemic is basically like anytime there's like an increase beyond what you would expect for any disease. And so, yes, I think it does meet the kind of typical epidemic definition. So
I think declaring a public health emergency is a really important distinction, just because it frees up resources. We've kind of seen since that declaration what it's meant on the federal level and getting vaccine out and getting resources, even on the citywide level, what it means to like get resources out. So I think that's a big important distinction, and it was declared, and we don't take those declarations lightly. I don't think that any of us should. But again, I think, to kind of, again, as we kind of get ready to wrap, this is something that the community could be concerned about. I don't think that we have to be afraid of, but I think we should be concerned about. I think certain folks may have a higher risk of exposure. And I think those folks in the communities, we have to hold them down to get information to those folks and get folks vaccinated and support those folks so that this doesn't extend beyond the communities that it's currently affecting. And I think that's it. I think the best thing that we can do is, learn more about this thing, have the conversations. And when we hear stigma, when we hear the blame, when we hear this otherization, to really step in and knock that down and not let that type of talk fester, because there, we know what can happen when we let these things divide and conquer us. So I guess as we get ready to wrap, we're at 2 o'clock. Yeah, we're at 2. We will let you all go. Have a safe and wonderful weekend. Enjoy this late summer Virgo season. Happy birthday to all the Virgos out there. I'm not a Virgo, but I like them.
All right, thanks all for spending your time with us.
All right, bye everybody. Thank you, Dr. Wong. Take care.